in 1968, the mortality of myocardial infarction was high. 58 patients, 21% died. This is an observation that we made in a small series and was led by Bert Sobel. Bert Sobel had developed a technique for estimating infarct size by measuring release of creatine kinase. So the idea of manipulating infarct size and the importance of infarct size was solidly in place from 71 to 81. Can we reduce the extent of ischemic injury in experimental models? Well, this comes from one of the papers together with Peter Libby, and what it shows is that the height of the ST segments when the dog was given Practilol, a beta blocker, decreased substantially. This became part of a large series of studies. The next thing that we puzzled over is if you administer reperfusion, does it actually salvage myocardium? We studied a myocardial infarct size by looking at the uptake of thallium-201 that was injected directly into the coronaries. And yes, there was salvage. The NIH established a study group that we call the TIMI study group, thrombolysis in myocardial infarction, and the very first trial that we did is we compared two thrombolytic agents, and you can see that TPA produced patency in 70% of the patients and streptokinase in 43%. So that was a good lead. But maybe the most interesting thing that came from that trial is that irrespective of whether TPA or streptokinase was used, a year following treatment, the mortality in patients who had still had occluded arteries when they left the cath lab, in red, you see, is about 15.5%. And it was reduced by 40%. But in patients with myocardial infarction, in this trial we studied anti-10A therapy, a new anticoagulant, a novel anticoagulant at extremely low doses. And here are the endpoints. 7,500 patients with myocardial infarction. You see the incidence of cardiovascular death went from 4.1 to 2.2%, a 40% reduction in hazard.